Thank you very much, Lauren. And I want to echo the thoughts about yesterday. That was very exciting sessions overall. And we want to continue from what the discussions yielded yesterday to see here today about the technology gaps and desired features and functionalities, as the actual session is titled. I want to welcome everybody on the panel, Professor Kullervo Hininen from Sunnybrook, Dr. Fred Wu from Columbia, and Dr. Ying Meng from also Sunnybrook. So I wanted to start with Kullervo to basically, if possible, summarize what is the current parameters or optimization of parameters that we have to go after, and then so we can identify also where the gaps may be.
So are you talking about ablation or?
Yes, I was actually going to ask you about ablation later, but you feel free to start. Ablation, blood-brain barrier opening, histotropsy, if you like.
So parameters. So ablation. So currently we can ablate in the middle of the brain. If we use bubbles, we could ablate outside that volume. So that work still needs to be translated to clinic. So I think the basic experiments have been done, and we are very close to translating it to clinic. It requires good monitoring and control, and the pressure amplitude levels are not too much higher than with open blood-brain barrier. With blood-brain barrier, I think we have functional parameters. Sonication-wise, devices seem to work reasonably well throughout the brain. There is still lots of unknown related to bubbles and different types of bubbles, and I don't think we have optimal parameters for different therapies, but that is work that will happen later after we saw that something worked in clinic. For synonym therapy, I think the parameters are still quite unknown. The clinical translation is very early. So I think that's kind of my summary.
Yeah, thank you. And I want to also turn it over to Fred to see what we can learn from radiation oncology, because we obviously radiation oncology has been around much longer for GBM than focused ultrasound, and we wanted to see our bar is pretty high. We wanted to get the optimal parameters for every single sonication, for every single opening of the blood-brain barrier, every single ablation, also the drug dose. That has been a burning question. How do you measure drug dose? So what is the current state of the art, for example, in that field, and what can we learn?
Yeah, I think the way I see focused ultrasound as compared to radiation is going through very similar processes. You're first making sure you can achieve what you want to do, but then slowly you're increasing your ability to modulate how the sound is delivered, to deliver BBB opening to a select area and whatnot. And so I think as you become more specific in terms of how your sound is delivered, there's a few things you need to consider. One, you need to understand your tumor type, meaning, for example, brain metastases versus glioblastoma are completely different. When you have edema from glioblastoma, it's most likely microscopic disease. You need to treat that. You need to have margins 2 cm or more to encompass it, versus brain metastases. The edema is usually steroid and treated focally. So the approach needs to be considered depending on the tumor type. The second thing I think needs to be considered in terms of how we develop focused ultrasound is the ability to deliver the sound on a clinical level for patients who have different functionality. Most of the trial people are selecting healthy patients who had a safe resection, but many patients have neurological deficits, require anesthesia, et cetera, et cetera. So long treatments are not ideal. Difficulties with setup are not ideal. These are things you need to consider. And then the last part I think needs to be considered is, this is in the setting, at least for focused ultrasound and blood-brain barrier, you're combining it with drug delivery. Drug delivery can be as frequent as daily to every few days to weekly to every few weeks. And so the ability to deliver sound clinically, whether it be stereotactic head frame placement or using NeuroNav or whatnot, it needs to be patient-friendly in order for you to achieve that. So I think those are the few big points to hit. And the last part is, as you become more specific with your ultrasound delivery, they're based off of mathematical modeling. So there's a way to do a QA process to make sure that what's theoretical is actual. That's very important as well.
Great, thank you. So along those lines, for the question, another burning question was about the treatment envelope, and I think Lervo touched a bit on that. So Ying, what do you think is the advantage of so far the state of the art, and how can we enlarge the envelope of the current techniques to make sure that we can cover every single location of where the GBM may be?
Yeah, that's a great question. So I think I see the treatment envelope as one, spatially, the different areas in the brain that you can target, as well as how much volume you can target in one sitting. So obviously there's been, we use the Insight Tech device, and obviously in the last few years has been significantly increased speed in terms of the efficiency of targeting. And a lot of that has to do with acoustic monitoring that is being implemented and has been implemented in many other systems as well. So that has dramatically enhanced the efficiency of our targeting, reducing our treatment time. In terms of spatial envelope, like which areas of the brain that we can target, we have targeted areas in the close to the brainstem, in the cerebellum, very low in the vermis, so as well as superficially in the brain where you might see METs more commonly. So we have so far found there are limitations like medial temporal lobe, very low in the temporal lobe tend to be more difficult, very posterior tend to be more difficult with the system that we use, but with BB opening, the envelope is quite wide. We have so far been able to target pretty much any lesion we've encountered.
So I'll come back to that because that's something also that Lervo touched on, ablation and BBB opening, and how we potentially can learn from both. So I also want to take the opportunity to welcome Dr. Woodworth, who's here with us. And if you don't mind, Graham, I'll ask you a question that about the combination of resection and treatment with focused ultrasound. And I think there was also questions when you treat before or after resection and where. So if you wanted to talk about your experience with that.
Sure. No, I think this has been a great stepping stone for the technology to be able to assess the tissues after focused ultrasound, and also to open the door for window of opportunity and phase 0 type clinical trials where we can assess the drug delivery, therapeutic delivery into these treated tissues at the time of surgery. So what we've seen in using the surgical resection-based approach is that the targeting is quite excellent, and that the tissue characteristics after focused ultrasound, blood-brain barrier disruption, are intact. We haven't seen, even in regions where we see these so-called T2 star changes on the MRI scan, we don't tend to see any evidence of microhemorrhage or other disruption of the tissues by H&E and other routine histopathological measures. So that's sort of confounding, because we were expecting to see something there when we almost in some cases we took the dose of the energy up to a high level to try to get some T2 star changes so we could analyze that. And we haven't really seen any marked cytoarchitectural differences or changes. So we still have to sort of understand better what's happening in that context. But I think it's a great stepping stone for the technology, for sure.
Great, thank you. So going back to the questions for a second, and the technical questions. So this is going to be asked for a question for Lervo. So there was how can we image the opening, and how can we confirm drug delivery? So what is the current reliable techniques, and how can we improve upon them?
So yeah, a good question. So currently in clinic, it's in looking at the enhancement with MR contrast agent. You could use radioactive materials to quantify the drug delivery. Maybe the best way to do that. like Ying said, there is this acoustic control features. Those are not really doing proper job yet, mapping things and specifying, but at least some of the lab experiments seem to indicate that you could do a fairly good job quantifying the opening with the acoustic emissions, and Elisa, your work also showing that, and spatially localizing it. But how do you quantify the amount of drug delivery? I think it's probably the radioisotopes are the only way to do it really well, or during clinical treatments. But that's how kind of what we are doing.
Yeah. And also going back to the question for ablation and combination with blood-brain barrier opening or with sonic dynamic therapy, or all these other techniques that have been so promising. Is there, I mean, on other cancers, for example, it has been shown pancreatic cancer that if you have a sequence of events of conditioning the tumor, you could actually enhance the probability of treatment with another technique. So with still focused ultrasound, but ablation before blood-brain barrier, or vice versa. What are your thoughts about that, Clever? Because I know that you have experience with both.
Yeah, so that's a very good question. So I think that for drug delivery, I mean, you could use like pre-sonications to make the blood-brain barrier more open. I don't think we have all the information yet. We haven't compared that to trying to maximize the drug delivery with different techniques, like different pulse sequences or very long exposures, or using multiple frequencies and so forth. So that question is still open. But usually when you are putting drugs in, you want to get as much drug as you can. So if you start ablating, then you block the blood vessels. And which could be after you've got lots of drug in, then you can ablate and have the drug inside, staying inside. So maybe that's one approach. We tried it many years ago, but it didn't seem to give too much benefit. It's the ablation is not trivial in brain, especially. So.
Thank you. And then as a segue to the clinical outcomes, obviously, we're here to try to, if possible, improve lives, but also hopefully survive them. So Fred, how do you think, what is the patient outcomes that we're after? What is the low-hanging fruit here compared to what is currently done in the clinic? And how can focused ultrasound, move the needle in the next few years, but also in the few decades? So what do you think is the short-term and long-term benefits?
So I think the hard part about glioblastoma in general, even with radiation, is even if you see progression, it could be pseudo-progression. There's so many possibilities. And now with blood-brain barrier opening, even ablation or whatnot, that sort of MRI assessment of tumor progression is not great. So I echo what was said yesterday, is that unfortunately, I think one of the primary outcomes, unfortunately, needs to be survival, which is a little bit more difficult. But on many levels of clinical trial, I think, early phases especially, to get a clinical indication for treatment does not necessarily have to be overall survival benefit. It could be quality of life benefit. It could be improved drug delivery. It could be some other indices that you show clinical benefit. So if let's say we have a drug that's radio labeled or something that can be visualized, and you can show improvement of drug delivery as a simple phase 1 or phase 2, 3, showing benefit to that, at least then you can move forward. I think having realistic endpoints is important for your trial design.
So Ying, I will ask you the same question, and then I go to Graham because I want to hear both your thoughts about that.
Sorry, the question was, what are the challenges of measuring
the short-term and long-term patient outcomes that you would like to see with compared to what we can do for GBM patients currently?
Right. Yeah. Absolutely. So I'll echo that it's hard to tell, obviously, from just radiographic response, whether it's response or pseudoprogression. Also, another challenge to treating GBM is the heterogeneity. I think it was brought up yesterday, a great point that we should be maybe looking at different population of glioblastoma patients rather than it overall in trying to improve the chance of having a signal from our trials. So, so looking at maybe IDH1 mutant populations or only selecting MGMT hypermethylated populations would be something to think about in future trial design.
Thank you. And Graham, how do you think we can improve going forward with the current technology?
Yeah, well, I think one of the important things to note, I think, in large part because of Kullervo's outstanding work, is that our technology is way ahead of what we know about how it can be used biologically. And when we're trying to address a disease like glioblastoma that is so diverse in its biology, we have to take a step back. And that's why I think these pre-surgical studies where we can actually look at tissue effects in the tissues themselves are going to be very important, so we can try to understand that biology and then tune the combinations together to achieve the desired biological effect. The setting of recurrent glioblastoma is the graveyard of good ideas, and if we go after combination therapies with focused ultrasound, with drugs that are sort of picked out of a basket of things that have failed because they, quote unquote, didn't cross the blood-brain barrier, and think that all of a sudden now they're going to work with focused ultrasound, we're going to be gravely disappointed. I think we have to be very careful where we apply this and how we apply it. I personally am very optimistic about applying it in the pre-surgical setting so we can carefully study what's going on, but then also in the upfront treatment of patients with just minimal residual disease, the so-called infiltrative margin of the disease. If we start going after patients with multifocal recurrence patterns, disease in various locations of the brain, it's going to be a very challenging scientific endeavor to understand what's going on. So I would favor, looking at this technology carefully and studying it in those two settings, the pre-surgical setting and in the setting of patients with minimal residual disease after surgery, the standard chemo-RT, which happens 6 weeks, and then usually about a month later, they start adjuvant therapies.
For the minimal residual disease, do you think, is there a promising technique that you see that can make the difference from ablation to sonodynamic to hisotropy, blood-brain barrier?
I think they all have potential. I think a start would be the blood-brain barrier mode of ultrasound. And I call it that because it may be doing more than just blood-brain barrier disruption, as we all know. So I call it blood-brain barrier mode or MBFUS or whatever terminology you want to use. But yes, part of that mode improves drug delivery. Part of it does other things that, again, we need to study. So I think that right now that's a promising technique because it's relatively low power. Again, thanks to Kullervo. It's low power, so it's relatively safe. We can treat large volumes, upwards of 60 cc's, with the Insightec system and probably larger with other systems. So I think it's a very promising way to apply the energy within the brain and then study it carefully.
Great. So we'll take some questions from the audience in the remaining 10 minutes. One question is with the MBFUS that Graham mentioned, what is the maximum volume that can be treated in GBM? I think Graham gave 60 cc's. Kullervo, you want to comment on that?
Or maybe Ying can comment what we are doing currently, but there is no theoretical limit really on the two. So
Ying, what is your experience for that?
So 60 to 80 cc we've done, but again, it's a limit based on a lot of different things. So patient tolerance of the time spent during the procedure, also the amount of homogeneous BV opening you want to have, the more larger targets you're placing with the current device, the more heterogeneous BV opening you're going to get. So if you want to have very even BV opening, we would tend to place smaller targets. I think with some of the technical introduction that was discussed in the presentations today, that's going to increase significantly. If we can get subsquat control on the targeting, then that the amount of brain volume that we can treat will increase significantly.
All right, thank you. Another question is, can the whole tumor be sonicated, and is microbubble dosing a limitation? I don't know who wants to take that question. Maybe
I can, yeah, sure.
Okay.
So the microbubble dosing kind of has to do with the drug monograph for DEFINITY, the one that we are using with our device. So it's indicated for cardiac imaging, and some of the and that dosing is based on the clinical trials that was run when they were trying to develop that drug. So theoretically, the half-life is very short for DEFINITY. Theoretically, you can have much higher doses administered to patients without any safety concerns. But the current maximum dose is based on the drug monograph produced by the company.
So that's a diagnostic, obviously, protocol that's used for cardiology, as you mentioned, and that we can already do 60 to 80 cc. So hopefully, in the future, we can do, better going beyond the diagnostic protocol, right? Another question is, would you suggest that T2 star observations may be a result of a bold defect in the tumor? So maybe Graham can answer that, since you touched upon the T2 star aspect.
Yeah, no, I do. I think there could be a number of possibilities that the T2 star changes represent. Microhemorrhages are still on the table, but certainly some type of bold effect. There's also a question of whether or not those changes are occurring before or after contrast administration, and whether there could be some deposits of gadolinium in the tissue. I don't think that's the case myself, but I do think there's some kind of extravasation of material into those regions that's leading to that effect. But it's hard to tell. I think with more of these pre-surgical studies, we'll have more tissues to analyze and be able to dissect that a little bit more.
All right. And the last question is about the response assessment. So if the blood-brain barrier opening is transient, why do we think that this is going to lead to issues associated with response assessment? So won't the blood-brain barrier changes be resolved by the time of a follow-up MRI exam, 1 to 3 months? Fred, do you want to take that? Or
Yeah, I can take it. So, a lot of that is in theory, and we can extrapolate a lot of that from radiation. So radiation in itself can also temporarily open the blood-brain barrier. And when we treat glioblastomas with radiation, they have, initially great response. But something biological happens and we can't explain it, is that there's pseudoprogression that happens. And on radiographics, it looks like tumors progress, but in reality, it's not. And so the reality is that even though we know that BBB opening is a transient effect, but the long-term effects on the vessels for repeated opening, how that affects long-term, access to the vessels, or what it shows ends up in terms of radiographic imaging could vary, and it's just a big black box right now. We don't understand it well enough.
all right. So in the remaining few minutes, I wanted to touch on the immune response that we see with the blood-brain barrier opening and ablation, and how important you think this is. Obviously, this is something that is kind of like an advantage of the technique that we're currently trying to understand, but how do you think this can be harnessed going forward? Can we work with looking at potential inhibitors, and how do you think that's important in the GBM realm? So maybe we'll start with Ying.
I think that's a great question. We have noticed in our patients some interesting radiographic findings, and we're in the process of looking at some histological specimens that were collected in patients after treatment, when they, if they do undergo treatment, surgery, to see if there are any interesting immunologic infiltration to the tumor tissue. It's something that we are actively studying We don't have, I think, enough data from the clinical trials to really make any solid conclusions on that yet. It's something we're very interested in looking into for sure.
Graham, do you have something to add on that?
Sure. I think that this gets a little bit into some of the limitations of some of our current animal models as well. It'd be really nice to be able to study this more effectively in preclinical settings, so we could look at not only the mode of ultrasound, thermal through mechanical modes, all the way into histotrypsy, but also over different time points. So when we think about being able to study this and model this in an animal, I think that's where we need to be thinking about this. I think in the human, it's going to take a long time to dissect all these things out with the types of studies that we're able to do now, meaning minimal tissues, and we don't really even understand the circulating biomarker impact of focused ultrasound very well yet. So there's a lot of work going on in that space as well, trying to understand if there's things we can tease out from the bloodstream or the CSF to help understand what could be going on with focused ultrasound. But personally, I think we need to dissect this in preclinical models and have focused ultrasound systems that can be as good as the clinical systems that we're working with and mirror the effects in a translatable way in the animal brain, whether that's a mouse or a rat or a pig or whatever it may be. So that's what I would think about in terms of understanding the biology in a deeper way.
Thank you. Yeah, it's always good to obviously keep in mind that some assumptions that we may be making don't always go from preclinical to clinical. It's a much more complex disease by the time you diagnose it in humans. And that's maybe this uphill battle that we all have to figure out. So the last question would be to Clervo, if what do you think is the most exciting thing about the technology going forward, and what do you look for in seeing in the future?
Oh, I mean, I presented my views in my video.
Yeah.
So we have invested. So we have invested lots of effort in trying to develop the next generation helmet, which is a custom printed helmet around patient's head, which is optimized for the target and uses a phased array technology, both transmit and receive, and can image the bubbles with very high spatial resolution and temporal resolution. So provides true control over the bubble exposures. And so far it looks very promising. So I hope we can take that to clinic and then be able to actually quantify what is happening inside the brain by spot. So it's very, very high resolution. So that excites me, but.
Okay, so maybe we can, so now that you said that, maybe we can get the clinical perspective. Is that also exciting to the clinical side about being able to monitor, everything that's happening at the same time as treating?
Absolutely. I mean, I think taking this into a precision patient-specific approach that would be outside of an MRI scanner, but have all the safety built into it and the controls built into it, that is absolutely the future. I think that's a really exciting development. And I'd be personally very excited to be implementing that in the clinic.
That's great. So, Ying? Yes.
Oh, yes, I totally agree. I think the two things that people three things that most people complain about when they are part of our studies. One is a head shave, so having their hair shaved, the head frame, and the MRI time. So if we can work on improving all those aspects, there'll be more people willing to participate in our studies.
Great. Well, the future sounds very bright. And I want to thank the panel and the audience. And I also want to remind everybody that the next session will start soon, but there's going to be a short break in between. So thank you again and enjoy the rest of the workshop.